Thank you, Chairman. Good morning, ladies and gentlemen, and learned colleagues. Before starting my presentation, I would like to pass on to you best wishes of Professor De Manzoni, that due to prior commitment cannot be with us today. My name is Simone Giacopuzzi. I'm assistant professor in Dr. De Manzoni team, and what I have to talk about is about the evidence in early gastric cancer. And I would like to thank the previous speakers because they give us a lot of information and make my work easier. No disclosure. So when we face an early gastric cancer, we have two options: endoscopic resection and surgery. Really, there's also the third way, that is an hybrid treatment, and we will talk about it after in the second part of my presentation. But endoscopic resection can be considered also only the first part of a strategy, because we can start with endoscopic resection, and once that we have displacement, we have to first spread up the spacement, pin on a flat cork and fixed in formalin solution, and margin should be inked. In this way, the pathologist can give us really important information. But the most important thing is to give to the pathologist an en bloc resection. And as reported by the previous speaker, and also in a series that we published in 2009, ESD has a higher number of en bloc resection than EMR. So for big lesion, ESD is the only procedure that we have to perform. With the specimen, the pathologist should give us some important information about lateral margin, vertical margin for sure, depth of invasion, and the histological type and grading, and if there's ulcers or lymphatic and venous invasion. Those are really important, but because we have to decide if our procedure was a diagnostic procedure or a therapeutic procedure. And one important point is to check for the agreement between the biopsy and the histology, because we know that more than 10% of cases there is a clinically significant discordance between biopsies and the final histology. And we have to know that only well-differentiated cancer can be treated with ESD, according to Japanese guidelines, but also with our guidelines that we published in 2015 with the GH group. And so they fit the standard criteria and then being considered cured by ESD, but there's also the extended criteria, and this paper published this year investigated the role of ESD for expanded criteria only in intestinal type, and they found that all patients treated with ESD had no recurrence after the procedure, but only 67% of patients had a curative resection. So for differentiated type cancer, there could be a technical problem, but it's not an oncological problem. In 2009, in Japan, they tried to insert in standard criteria also the undifferentiated type tumor, but there are discordant results about it, and in 2016 I think that is one of the largest series in undifferentiated tumors fitting the criteria, so less than 2 centimeters. They report 2.3% of lymph node metastasis. So I think that this tumor should be treated with a standard surgical procedure, and we think that in Western countries probably expanded criteria are too expanded, also according to our series, but it's quite hard to compare Western to Eastern countries. First of all, due to the terminological dichotomy, because in Japan, they use undifferentiated and differentiated. We use in Europe, we use usually diffuse or intestinal gastric cancer. And inside this classification, this group of patients, there are also another group of patients, that is Signet ring cells, is not the same. Diffuse and Signet is not the same, are two different tumors, are in the diffuse but are not the same. And the Signet ring is increasing in the rate of detection. So we have to start to consider the problem about Signet ring cells. Also because not all the results are the same. For early gastric cancer, there are some authors that report are really bad prognosis for Signet ring cells. For other authors, the prognosis is pretty good in early gastric cancer, and there's also a paradoxal better survival in Signet ring cells compared to non-Signet ring cells tumor in early stages for some other authors. So probably the problem is that not all Signet are the same. And so we are trying to classify more properly the Signet ring cells. This is a paper published by Korean, but we have done something similar last year with our European consensus that we had in Verona, in my city, in 2017. And we divide the Signet ring cells in three groups. The pure Signet ring cells, with more than 90% of Signet rings into the tumors. The poorly cohesive with Signet ring cells component, if the number of Signet ring cells were between 10 to 19%, and the poorly cohesive not Signet ring cells. We are trying to understand if there's a role in survival of this classification. We try to validate our proposal, and in our data, we realized that the mortality for poor Signet ring cells is less than non-pure Signet ring cells. So probably there are two different tumors with two different differentiation. But the future probably is to consider the molecular classification. At the moment, it has no relevance in clinical practice, but we know some important things. For example, microsatellite instabilities has a really low rate of lymph nodes compared to genomically stable patient or with a patient with epithelial-mesenchymal transition, where the rate of lymph node was higher. So if we have to think about expanded criteria, probably we have to focus on the genomic pathway. There are really few data in the literature. This is one important paper published last year, and the author find that EMT markers is an expression of independent predictive factor for lymph node metastasis in patients with early gastric cancer. So if we have an epithelial-mesenchymal transition, this group of patients could not be treated with ESD. So once again, poorly cohesive histologies, submucosal tumor, genomically stable patients are conditioned with high risk of lymph node metastasis, and ESD is not enough in this group of patients because the rate of lymph node metastasis is pretty high. So we have an option that is the hybrid treatment with endoscopic submucosal dissection, with laparoscopic sentinel lymph node dissection, and using sentinel node navigation. The pros obviously is that is less extended resection, reduced postoperative complication, and we know we have no post-gastrectomy syndromes. But data about false negative occult metastases and sensibility are not so conclusive. I think we have two important papers here published in Japan. The first one published by Kitagawa, and the false negative rate was 7%, so very, very small. And I think that in this case, we can consider lymph node navigation as effective. But the other paper, the accrual was stopped because the false negative rate was really, really high. We have to wait for this paper. That is, the name is very funny. This is Senorita Trial. That is Korean one. And the design of the paper is very, very important because in experimental arm, they considered lymph node navigation, and if was negative, they use ESD for treatment or wedge resection for treatment. But we have no result at the moment. But what we can say is that hybrid treatment can be a bridge between ESD and the gastrectomy in early gastric cancer with high risk of lymph node beyond the ESD indication. But a part of this bridge is gastrectomy. So which gastrectomy, which approach, laparoscopic, open approach? For distal gastrectomy in early gastric cancer, I think that there are no doubts. These two milestone papers confirm that there are no better short-term outcomes with open compared to laparoscopic treatment, but laparoscopic treatment is better for the complication, the postoperative period. We have no, at the moment, the long-term result is not still published, but we know at the ASCO meeting that the class 1 reported a really important result for laparoscopic assisted distal gastrectomy. But which is the lymphadenectomy that we should perform? We think in Italy, with our group, that we should do a D2 dissection, because the number of lymph nodes involved in early gastric cancer is pretty high, mainly in diffuse gastric cancer, and more than 10% of lymph nodes were in the second tier. So the only way to remove this group of lymph nodes is with D2 dissection. Talking about total gastrectomy, I think that should be considered carefully, because at the moment we have no definitive data on the randomized clinical trial. This is a really large series from Korea, and they reported that laparoscopic assisted total gastrectomy is an independent risk factor for postoperative leakage in the anastomosis. But I've already told you that at the moment we have no published result. I think that Dr. Jung, after my presentation, will give some result about it. But looking at a real life disease, I think that is a really important paper. That is a retrospective cohort study from National Clinical Database in Japan, and they found that there is no difference in mortality, shorter hospital stay for laparoscopic approach, but with a higher incidence of readmission, reoperation, and anastomotic leak. So I think that total gastrectomy cannot be considered the standard laparoscopic total gastrectomy cannot be considered the standard for us also in early gastric cancer, but should be considered investigational in high volume center. And would like to leave with these few words by Robin Cook, and I think that with cooperation they are not true. Thank you so much.